right. Thank you, Evan. As Evan mentioned, I am a clinical psychologist and associate professor here at UCSF. And I wear a number of hats, but I'm really focused on accessible and culturally appropriate services for youth and families. I have a particular sort of expertise in ADHD and school-based treatments. And so I'm always really happy to see school folks here as well as others. And today, no problem, Jessica, no problem. Well, we're hoping other folks will trickle in too. I know sometimes it's hard to remember the first one of a new series. So today we're going to be talking about single session consultation and how it overlaps with common factors. Before we launch into that, we just want to give a shout out that our service, which was formerly called CAP, is now called CalMap. Same service, just sort of new name and more of a statewide reach. And if you want any guidance on how to kind of apply some of the things we're talking about today, we really encourage you to call or request a consult. And also, we're not going to be doing a big introduction about the Project Echo model. So if you'd like more of an introduction and sort of background on how this model works, please go to our therapeutic skills series page on the CalMap, and there's a video and slide deck from our first ever series of this, and so you can take a look at that. So I don't have any personal disclosures, and you can see here that CalMap is supported by various federal and state grant funding sources. But let's jump right in. So today we're hoping that by the end of this, you'll all be able to identify 4 reasons to utilize a single session approach to motivate positive change from youth and their caregivers, and as few as 1 brief interaction. We're also going to talk about how you can adapt the single session consultation model for use in everyday primary care or school settings to support youth who are in need of behavioral health services. And then lastly, making 4 connections between the single session consultation and common factors skills. All right, so we're going to start today's echo with an introduction of and rationale behind the single session approach. And I just want to give a huge shout out to our partners at the Lab for Scalable Mental Health, who are very, very generous in providing open access materials. Please feel free to visit their site for those materials. And then our site has the materials that we've adapted specifically for primary care in school settings. Okay, so you might be wondering, how could we make any real meaningful change for youth experiencing behavioral health concerns in just one interaction? And why would we even attempt this? So as you know, one of the reasons you probably signed up for this echo is that we have far more youth in need of behavioral health services than we have specialty providers. And even if we doubled the number of mental health providers overnight, which obviously would be a feat in of itself, we still wouldn't be anywhere near what we need in order to really meet the need of the current mental health crisis we're experiencing, not just in our country, but across the globe. And so, as you all undoubtedly encountered when trying to make behavioral health referrals, there are a multitude of barriers that make traditional services infeasible, including the time it takes for families and youth to participate, cost, travel needs, just to name a few. And so what the research shows us is across a variety of clinical trials, the most common number of sessions someone ever receives for behavioral health is 1. So even if someone is linked to care, sometimes, in fact, more often than not, we only get 1 interaction with them when they first present with a problem, only to then not again see them, or they don't respond, or there's some barriers that are preventing more sessions than that first. And so given these facts, there's been a movement to purposefully design treatments that can provide powerful and sustained change in just a single encounter. And fortunately, research shows us that these can be effective. So these are just a few examples. I'm not going to read through all of them, but the takeaway here is that studies demonstrate that single session or brief interventions can have at least comparative effects in terms of reducing psychological distress and improving mental health in comparison to longer term treatments. And these findings really align with what we call Parkinson's law in psychotherapy, which is the tendency for therapy to expand or contract to fit whatever time we actually have. And so more and more research is finding that more sessions does not necessarily equate to better outcomes, even though that might go against kind of what we common sense think would be true. So what are single session interventions? They are defined as a specific structured program that very intentionally involve one visit or encounter. They can be with a clinic, a provider, or even a self-guided program. SSIs are a therapeutic treatment delivery strategy, not a specific orientation, like CBT or psychodynamic therapy, for example. It's an approach that really can be applied to a wide variety of treatment strategies. So it involves having the provider engage with the idea of a single session mindset, which really means that you believe this person already has everything they already need inside of them to enact meaningful and beneficial change in their lives. And you really believe that that could happen after just one encounter. And there are a lot of different ways of practicing SSI, but they all have in common this idea that what we have is now, and right now is enough. So some key assumptions that we'd like to think about when we're dealing with SSIs are that, one, we assume something good can come from one session, and one session might be the last. Two, we assume that change can, and honestly is expected to, occur in the moment. So we set our change expectations pretty high. And three, we assume that a person already has the inner capacity to alter their thoughts, emotions, and behaviors in order to bring about the kind of significant and beneficial change they might be looking for or they might need. So these might all sound similar to strengths-based approaches that you may have learned in different areas of your practice. And indeed, there are a lot of overlaps in terms of empowering a person to believe that they already have what it takes to bring improvements they need. Okay, so why and how can one session be helpful? First of all, when you're offering a single session intervention, you're often dealing with a motivated individual. They're talking about a need that is most concerning to them in that very moment. And so they're likely pretty motivated to address it. And working with motivated people can lead to happy providers because you're dealing with someone who seems like they really want to be there and engaging in some sort of change. And happier providers tends to lead to happy individuals because individuals report greater satisfaction when working with someone who seems enthusiastic to be there with them. We also know that studies show that the most amount of positive change happens really early in the therapeutic process, even in longer term traditional therapies. So single session interventions can reduce overtreatment, such as keeping someone in for weeks or months when they really might not need that. And all of this can help reduce our extremely long behavioral health waiting list, which is a consistent concern we've heard from our CalMap users that matches national trends. So we'll talk more about the evidence for that last point in just a moment. But first, let's look at a specific model of single session intervention that we'll be focusing on today and throughout this entire therapeutic skills series. Actually, before we do that, I just wanted to point out some free online self-guided single session resources that you can provide to your youth or the caregivers of the youth that you work with. I give these out all the time. They're really, really helpful. Research shows that they're effective. And so Project Yes, Youth Empowerment and Support, offers a free, anonymous, brief, self-guided mental health tool for teens, and it's available in several languages, including Spanish, and it empowers teens to learn new ways of dealing with stress to help others do the same. It was designed for teens in mind, but anyone really can try Project Yes. And it's run by scientists at the Lab for Scalable Mental Health with partners at University of Texas Health Center at San Antonio, University of Miami, and Lebanese American University and Ankara University. And then we also have Project Empower, which is designed for caregivers. It's a free science-backed one-session online program for parents, and it teaches them skills to build bravery and reduce anxiety in children and preteens. And it's available in English, Spanish, and Creole. Again, it was designed for caregivers in mind, but really could work for anyone who cares for children, yourselves included. And anyone's welcome to try these. They're free, they're anonymous. They don't collect, Project Empower doesn't collect any personally identifying information. And again, it was built by clinical researchers at the Lab for Scalable Mental Health. Okay, so next let's talk about a specific type of single session intervention that we believe can be adapted to fit all of your practices. It's called single session consultation. And so single session consultation is an SSI model based on the principles of solution-focused brief therapy, which adaptations here and there in order to maximize the fit of just one session and really make this as useful as possible for both kids and adults with a variety of mental health difficulties. So single session consultations have been and continue to be tested with individuals who are on wait lists for longer term traditional kinds of mental and behavioral health care. And in these trials to date, we see that satisfaction ratings have been really high, reflecting that people thought the single session consultation was helpful. They appreciated the action plan that was co-developed. They believed it was useful. They felt motivated to use the action plan, and they would recommend single session consultation to others. Across these studies, we see that hopelessness showed an 85 to 87% chance of decreasing. Readiness for change showed a roughly 80% chance of increasing. And perceived agency, or the idea that someone really believes they have some sort of control and autonomy over their life, also improves from before to immediately after. And really importantly, anxiety and depression symptoms, as well as psychological distress, improved at the 2-week follow-up. So interestingly, researchers in these trials have found that many people who, again, were on wait lists for traditional services actually took themselves off those wait lists after receiving the single session consult because they felt that was all that they needed. And so this is why we think training primary care and school providers in single session consultation may really help reduce our national waitlist crisis. Okay, you might be thinking, can I actually lead one of these? I'm not a therapist. I wasn't trained in this, right? Research shows that single session consultation can be effective even when delivered by individuals who are not trained as therapists. And the developers of single session consult acknowledge that not everyone will conduct a full model consult as it's designed. That's not an expectation. The skills and the tools in this model can be used in a variety of different environments and contexts. In our CalMap work to date, we found that training primary care and school providers to adapt and deliver single session consult, we indeed heard many success stories of providers finding this model helpful, either by using the brief protocol that we developed, which we'll share with all of you in its entirety, or by using aspects or features of the model that align with these common therapeutic factors. So we'll go over the steps of how it was originally designed, highlight main points from each steps, and then we'll discuss how the model can be adapted to fit your practices. So these are the steps of a single session consult broken down into 3 main areas. First is establishing the readiness of a youth or a caregiver. You're going to help them narrow in on what they want help with and explore what they hope to get out of talking with you. The next step is assessing where they are with that problem today, how far away they are from their goal related to the problem, and what they've done in the past that has worked that could be helpful to try again to get them closer to their goal. And then finally, we get to the consultation part. What are we going to do about this problem and help them construct a concrete and realistic action plan? So the tools that we use in an SSC are an action plan. This is what you'll fill out with the person and then they can take it home. And then there's also a guide for you as a provider leading the interaction. It's sort of like a script. And then just in case, it's always helpful to have risk assessment materials in case something comes up that is you need to take action on immediately to make sure everyone's safe. And that's it. So again, we have the original single session consultation materials that are linked and QR coded. And then we also have ones that we've adapted with the goal of fitting in a 20 to 30-minute interaction, which is probably more realistic for all of you. All right, so how do you start? So if someone you're working with seems like they might benefit from this single session consultation, you could say something like, I'd like to talk more about what you just brought up if you're open to it. Our aim for this talk is to be goal-directed, focused, and oriented towards creating a coping plan for you to use right away. So before we get started, I want to make sure that now is a good time for you to try something like this, right? So it's important that before this, we've sort of assessed privacy and safety. If risk is imminent, you're not going to delve into a single session consult, right? You're going to do risk management, which we have other webinars and echoes on that I'd encourage you to check out. And here you're really asking for permission that they want to try this. So next we want to hone in on their main concern. And to do this, we want to make sure we're reflecting and we're validating. We're not trying to fix anything yet. We're not trying to diagnose them with anything. We don't want their entire life history or their whole background. We just want to narrow in on one specific small thing that we can focus on today. And once you narrow that down, you summarize it on the single session consultation action plan worksheet. This step, I'll admit, can be trickier than it seems, which is why we'll be practicing this in our case-based learning every month throughout this series. Some general tips. This top problem should be something that's modifiable with intervention and something that matters to them. It can be a feature of a larger problem, right? So for example, let's say you're working with a teen and they say, well, nobody likes me at school. Well, that's not really something that we can fix with intervention, right? I can't go to their school and get everyone to like them, but how can we narrow that in on something that is actionable? I'm struggling to connect with people at school. Here's another example. My child won't get out of bed. Again, like we can't actually force that child to get out of bed, right? But we don't have an effective morning routine. That's something, a smaller chunk that is actionable on our part. All right, so next we help reframe the problem into a hope, a goal, or a desired outcome. So if the top problem was, I'm struggling to connect with people at school, what's the positive opposite of that? Again, ideally something realistic that we could have an impact on. For example, I could make a connection with a classmate, right? That's more realistic than everyone will like me. And again, this step can be tricky, which is why we're going to keep practicing this. If the top problem was we don't have an effective morning routine, a positive opposite that's realistic would be we set up a morning routine with clear expectations and consequences for getting out of bed and getting to school. All right, so then we move into phase 2, which is where we have them self-assess where they are today with this top problem. To do this, we pose what's called a miracle question. So if you had this problem and overnight, everything cleared up, a miracle occurred while you were sleeping, and the reason for this problem just disappeared. When you woke up, how would you know there was a change? How would your miracle appear to you? What would look different, right? And this can really help us understand maybe some of the ways that that problem is impacting them or how they're getting stuck, how things that used to work aren't working anymore. Right? So let's take our first example about connections at school. A miracle occurred. How would you know? I wake up in the morning and I'm not super stressed out. I can go to school. I feel like I can just be myself and get along fine with my classmates. Right? What about our example of the morning routine? We all wake up, come downstairs, dressed, and eat breakfast together. Everyone's in a good mood and we get to school and work on time. So next you ask them on a scale of 1 to 10, with 1 being nowhere near your goal of a top hope and 10 being, I feel amazing, everything is perfect, where are they now, right? So let's say our connection at school says a 3, our parent says a 4. So after they quantify how close to their goal they are, you ask them to describe why they decided they're at that level and not one step higher or lower. And so this is how you can tell a lot about how they really see themselves now and what it might take to get them just a little bit higher on that scale. You're also trying to uncover strengths that they already have in their toolbox that's helping them prevent it getting worse, that maybe we can shore up, right? So some questions you can ask in this stage: can you recall a time when you thought you would be overwhelmed by this problem, but you weren't? Can you remember a time where you were even 1 point higher on the scale? Can you remember a time when you felt good about how you handled this problem? What did you do? Right? And note here, we're still not making any suggestions for them to change. We're still not fixing anything. Right? So for example, let's say our teen says, I'm a 3, I'm not a 2 or a 1 because in a couple of my classes, the other kids aren't so bad and I can focus and get my work done, but I really want to be closer to a 10. Okay. Our parents say we're at a 4 because it's a little bit better than last year when she wasn't getting out of bed at all. At least she's getting up some days. I just wish it wasn't such a huge fight every morning. Okay, and now we finally get to consult, right? We finally get to work on this action plan. So you're going to help them identify very specifically about when and where they can actually take an actionable step towards getting even 1 point higher towards their top hope. If they say like, I don't know, or I can't remember, really rely on the discussion that you've had with them so far and windows that they brought up about when things might have been better. Ask whether moments that they've talked about earlier might represent small upticks in their rating. Another option, if they're really stuck, they just say, I don't know, I'm super stuck on this problem. You could just praise them for being open to talk about this problem in the first place and ask them what helped them make that choice to take such a positive step today towards their future. And you might also get a window here to provide some tips or new skills for them to try. And again, since we don't have 8 to 12 sessions of therapy, we don't want to just leave them feeling like they have their action plan on their own. So we're also going to have them come up with supportive people they can connect with that can help them do these activities together, and that they can reach out to if they need help. Right. So, for example, our teen, maybe they decide, well, I could try to start a conversation with the kid who sits next to me in science. He's pretty nice. Okay, when am I going to do it? Tomorrow, before the bell, where? In science class. 2 people who can help me, my school counselor and my mom. Maybe the parent says we can have a family meeting to talk about setting up the routine Thursday night at the dinner table. And then if you have time, we can help them think through what might be something that would get in the way of them doing this action step, and then how could they overcome that? Right. So, and again, here's where you can really trickle in some skills that we're going to talk about throughout the series, like helpful thinking and opposite action. So, for example, if our teen says, well, I'm afraid I'm going to chicken out because I'll sound dumb if I try to start a conversation with that kid in my science class. Some helpful thinking would be like, do you really think that the kid's going to think you're dumb? Like most people are pretty focused on actually themselves and don't even really think twice about other people and what they say, right? He probably won't think anything of it. So if I get overwhelmed, I'm just going to remember, you know what? No matter what happens, it's not the end of the world, right? The parent might say, well, I'm afraid I'm really going to avoid this conversation because I don't want to cause a huge argument. I know I've done that in the past. So what I'm going to do, I'm going to make a plan with my partner ahead of time. And when I feel that urge to avoid the conversation, I'm just going to focus on getting it started and remind myself it's okay if we don't come in with a perfect plan in one night. We're just going to get the talking going. And then it's really helpful to leave them with some words of encouragement. This could be something you write in their note, something you send them away with. It could be spoken, just some sort of reflection on how you really feel confident that they're going to follow through and make some positive change. So you might be thinking, I already do a lot of the essence of what you just talked about in my work, even though I've never been trained in single session. And indeed, you do not need to be a therapist to be therapeutic. You're likely already employing what we call common therapeutic factors. And let's take a look at how these tie into what we just talked about. And again, shout out to our CalMap team. If you'd like to hear more about common factors, we have a whole webinar that you can access on the site. Just briefly, common factors are communication skills that are present across all forms of effective mental health treatment that help establish therapeutic relationships between providers and the people they work with. They address hopelessness and they instill motivation towards positive change. HELP is a common factors acronym standing for hope, empathy, language or loyalty, and permission, partnership, and plan. So I hope you saw how the single session consultation action plan addresses all of these, right? You start by asking permission to talk with the person more about their top problem, and you partner together to come up with a concrete action plan, right? All the while, you're really empathizing, reflecting, and validating as you hone in on their top problem and assess where they are today with it before you get to any action steps or solutions. And you instill hope by reinforcing strengths when you construct and send them away with their action plan. And all throughout, you're using the same language that they're using, not clinical language, and you express loyalty as you share those words of encouragement for them. So to summarize, both of these single session consultation and common factors are transdiagnostic. They're really helpful for a wide range of mental health symptoms. They serve as brief interventions that can be done in primary care or school settings with children and adolescents and or their caregivers who have emerging mild to moderate mental health symptoms. We have research showing that they do reduce distress and mental health symptoms while people are on wait lists for more specialty care. And actually, they address barriers to care because a lot of people find they don't need more sessions after they do a single session consult. So if you would like to see what this looks like outside of our ECHO groups, which are going to be, doing single session throughout, we have an online self-guided single session consult for primary care and school providers that we co-developed with this Lab for Scalable Mental Health. And so to complete this brief web-based activity for managing burnout and thinking about your work in new ways, you can visit this QR code or link, and this activity can be beneficial in two ways. It can show you an example of a single session consult and what it feels like to participate in one. And then it also may be helpful in addressing your burnout as a provider. So I'd encourage you all to take a look at that.